Hi everybody, it's Adam with HeartValveSurgery.com, and we're in Los Angeles, California at the Society of Thoracic Surgeons Conference. I'm thrilled to be joined by Dr. Bill Brinkman, who is a leading aortic valve surgeon at Baylor, Scott & White, the Heart Hospital Plano in Plano, Texas. Dr. Brinkman, you and I have known each other for a very long time. As always, it is great to see you, and thanks for being with me today at STS.
Thank you so much. Yeah.
So, Dr. Brinkman, you and I, one thing we like to talk about is the Ross procedure. One, I'm a patient, and two, you're a Ross procedure specialist. Mm-hmm. And what we've seen is over the last 6 years, an 8 times increase in the number of Rosses performed in North America. Mm-hmm. I'm real curious to know, what are you, your cardiac center, and other teams that focus on the Ross doing to manage this growth, given the Ross procedure is so unique and complex?
Well, that's a great question. We have a group, a consortium, the North American Ross Consortium we've developed with our team at Baylor, Scott & White in Plano, the University of Washington in Seattle, Northwestern University in Chicago, and University of Pennsylvania, all very experienced Ross centers. We had a meeting today. We're compiling our data and looking at outcomes and getting very granular on the technical aspects of the procedure to try and standardize it. The Ross requires a master surgeon. There's a lot of artistry to it. But what we want to do is also develop some guidelines, some recommended techniques with certain anatomic situations. Exactly what NARC is looking at, because there are many different ways to support the autograft, and that's a critical aspect of making sure it's stable and have stable long-term outcomes with the Ross procedure. Some people support it in a Dacron graft. Some people use native support. Some people put it in a subcoronary position. And you have differing opinions on how they replace the right ventricular outflow tract, the pulmonary artery, all of which techniques can work. But I think there's debate on which technique might be the best with which anatomic situation. And that's what the NARC is trying to help surgeons get to the bottom of. Move it a little more from art to more of engineering. And that's what we're doing with this. It's going to lead to better long-term outcomes in refinement of the technique.
Last question for you is, doing something like NARC often takes some resources and funding. Is anybody helping you, Baylor, Scott & White, University of Pennsylvania, Northwestern, and UW Medicine in Seattle, to get the NARC up and going and off the ground?
The individual sites have some intramural funding, but the primary resource of our funding is a company called Artivian, and they've generously donated a significant portion of money. They also are the people who provide the homographs when we reconstruct the RVOT or where the pulmonary valve was. So it's in their best interest also to support the Ross and make sure it grows well, because they want it to be a sustainable, good procedure for the future.
Yeah, well, what I love about what you're talking about is it's a community effort. It's not just about the surgeon, it's the team, it's the cardiac center, it's Artivian, it's educating people about all this great work that you're doing. And on behalf of the patients, it is always great to see you, Dr. Brinkman, and thanks for everything you're doing at Baylor, Scott & White, the Heart Hospital in Plano, Texas.
Thank you so much for this opportunity to talk.
Hi everybody, it's Adam. I hope you enjoyed that video. And don't forget, you can always subscribe to our YouTube channel, watch the next 2 educational videos coming up on your screen, or click the blue button to visit HeartValveSurgery.com.